My talk today is about NK1 receptor antagonist and how to make the most of available medications. Okay, these are my disclosures. It is thought that chemotherapy induces nausea and vomiting by releasing certain neurotransmitters, such as serotonin in the gut or dopamine and substance P in the central nervous system. Therefore, a pharmacological approach to prevent chemotherapy-induced nausea and vomiting was to design antiemetics that would block these neurotransmitters, for example, dopamine D2 receptor, serotonin type 3 receptor, and NK1 receptor for substance P. The recent advance was the invention of NEPA, here in blue. NEPA is the first combined antiemetic where netopitant and palonosetron are combined, and unlike the other antiemetics that block only one receptor type, NEPA blocks two receptor types at once. These are currently approved NK1 inhibitors, aprepitant and its IV prodrug fosaprepitant, rolapitant, and netopitant, which is never used alone, but always with palonosetron in a fixed combination in NEPA. NK1 inhibitors are recommended for CINV prevention in combination with other antiemetics for single-day chemotherapy. Aprepitant is also recommended for multiple-day cisplatin and high-dose chemotherapy, and these medications should never be used for the rescue treatment of established nausea and vomiting. Here you can see MASC ESMO guidelines for the prevention of acute CINV after single-day chemotherapy, and NK1 inhibitors are recommended for high emetogenic chemotherapy, either non-AC, for example, cisplatin-based, or AC containing anthracycline cyclophosphamide combination for patients with breast cancer, as well as for carboplatin. The indication for carboplatin represents the latest expanded indication for these medications, after it was observed that carboplatin is the most emetogenic agent in the moderately emetogenic group. This year, one meta-analysis was published that further supports the benefit of adding an NK1 inhibitor into the regimen for the prevention of nausea and vomiting after carboplatin. And here you can see the results for complete response. The addition of NK1 inhibitor in blue resulted in significantly better complete response rate, especially in the delayed and overall period, where the difference was more than 10%, which is also considered by MASC as clinically relevant. And the same result was achieved for no nausea. The difference, especially in a delayed and overall period, is again more than 10%, which is clinically meaningful. The meta-analysis that I've just shown didn't include NEPA, so I'd like to present here the results of NEPA and aprepitant palonosetron in the carboplatin subset of patients from the one of phase 3 NEPA trials. The regimen based on NEPA in blue and based on aprepitant palonosetron in gray are presented together on this slide, although the comparison was not formal. You can see that NEPA achieved very high overall complete response rates from 80% in the cycle 1 up to more than 90% in subsequent cycles. And a similar result was achieved for nausea. Overall no significant nausea rate was 84% in the cycle 1 and up to 96% in the cycle 4. And this is the only trial that evaluated the efficacy of NK1 inhibitor in multiple cycles of carboplatin, and based on these results, NEPA is also recommended for carboplatin. This is another meta-analysis that evaluated the benefit of adding NK1 inhibitors in the prevention of CINV after carboplatin and oxaliplatin. And while the benefit is well documented for carboplatin, it is still discussed for oxaliplatin, and this meta-analysis gave us the answer for all 3 categories of response: complete response, no emesis, no nausea. Absolute relative difference was more than 10% only for carboplatin. As I said, this is clinically relevant, so today NK1 inhibitors are recommended for carboplatin but not for oxaliplatin. So having covered the guidelines for the use of NK1 inhibitors, I'd like to ask you, what would be your main criterion when deciding which NK1 inhibitor to use? Efficacy, one is more effective than the other. Safety, one is better tolerated than the other. Pharmacology, for example, availability of different routes of administration, drug metabolism, potential for drug-drug interactions. And finally, convenience of dosing schedule, how simple is to implement it. So please vote. So for those of you who have voted for efficacy, let me tell you that the guidelines consider all NK1 inhibitors as interchangeable based on clinically relevant improvement in complete response for CINV prevention, so you may use any of them. Vomiting is better controlled than nausea with these medications. The review on data on chemotherapy-induced nausea prevention from pivotal NK1 inhibitor trials revealed differences among NK1 inhibitors, with NEPA showing the most promising profile. Of course, these data were non-comparative until this year, when the first direct phase 3 head-to-head comparison was published. And here you can see the design of the study. This study compared the NEPA-based regimen with the prepitant-granisetron regimen in chemotherapy-naive patients scheduled to receive their first cycle of highly emetogenic cisplatin-based chemotherapy. And this study was an international study conducted in Asia. NEPA-based regimen was compared with the prepitant-granisetron-based regimen. Both were combined with oral dexamethasone. NEPA was given only once per cycle on day 1 only, and the prepitant followed a standard 3-day regimen. And these are the results. The aim of the study was to document non-inferiority of NEPA, and as you can see, by complete response, NEPA was non-inferior. In the overall period, 74% of patients treated with NEPA were completely prevented, compared to 72% of patients receiving prepitant-granisetron. And the same result was achieved for no significant nausea. So non-inferiority was demonstrated also for nausea. In the overall period, 76% of patients treated with NEPA were without no significant nausea, compared to 70% of patients in the prepitant-granisetron arm. Another way to look at the efficacy is to evaluate quality of life and the impact of nausea, vomiting, or both on patients' daily living. And here you can see it for both NEPA in blue and the prepitant-granisetron in gray in the acute and delayed phase. In the acute phase, there was no difference between the 2 treatment arms. A similar percentage of patients reported no impact due to nausea, vomiting, or both. However, in the delayed phase, there was statistically significant difference in the nausea domain. 71% of patients treated with NEPA reported no impact on daily living due to nausea, compared to 65% of patients receiving aprepitant and granisetron. And to me, this slide also nicely illustrates how vomiting is generally better controlled than nausea with NK1 inhibitors. Higher percentage of patients reported no impact on daily living due to vomiting compared to nausea in the acute, in the delayed phase for NEPA, and the same pattern was also shown for aprepitant granisetron. So efficacy is not of much help when deciding which NK1 inhibitor to use. For those of you who have voted for safety, let me say here that generally toxicity profile of oral formulations of NK1 inhibitors is low. These medications improved CINV prevention without significant safety concerns, including cardiac safety concerns. In the first head-to-head comparison study that I've just shown, NEPA and the aprepitant granisetron showed similar incidence of adverse events. Most common treatment-related adverse events were constipation and hiccups of low frequency and of mild to moderate intensity. In the non-formal comparison of NEPA and the aprepitant palo, again, a similar incidence and type of adverse events were observed in single and multiple treatment cycles. And the most frequent NEPA-related adverse events were constipation and headache. On the other hand, safety may be an issue with IV formulations of NK1 inhibitors. This year, the distribution of rolapitant, of IV formulation of rolapitant was suspended in US due to anaphylaxis, anaphylactic shock, and other serious hypersensitivity reactions. The risk of serious hypersensitivity reactions is also reported in the product information for IV fosaprepitant. In the clinical development program for IV NEPA, similar safety profile to oral NEPA was observed, no infusion site reactions. And although there is a potential risk of hypersensitivity reactions due to palonosetron component, these reactions so far didn't occur. So, this brings me to my second question. When selecting among the antiemetic regimens of similar efficacy and safety, what would be your main criterion? Cost, pharmacology, or convenience of dosing schedule? So please vote. More than half of you voted for cost, and then almost half convenience of dosing schedule. Okay. So let's pretend that we live in an ideal world where cost is not an issue, and let's focus on two other criteria, that is pharmacology and convenience of dosing regimen. All NK1 inhibitors are highly selective for NK1 receptor and have a high affinity for this receptor. All of them are metabolized through CYP3A4, aprepitant more extensively. Therefore, aprepitant has a much shorter half-life than the other two and has to be given in a 3-day regimen, while netopitant and rolapitant are given once per chemotherapy cycle. As I said before, aprepitant and netopitant both have oral and IV formulation, netopitant in IV NEPA, and IV formulation, distribution of IV formulation of rolapitant has been recently suspended. Drug-drug interactions, this is an important aspect of pharmacology. Both aprepitant and netopitant are metabolized through CYP3A4, aprepitant more extensively. Both of them are also inhibitors of CYP3A4. This may lead to the increased exposure to medications which are metabolized through CYP3A4 if they are co-administered with aprepitant and netopitant. That is why you should reduce the dose of dexamethasone and monitor for adverse events with midazolam and some chemotherapy agents metabolized by CYP3A4. And this interaction with chemotherapy agents so far is considered non-significant because although there is an increased exposure, the incidence of adverse events is not higher, so there is no need to adjust the dose of chemotherapy. The drug-drug interaction profile of aprepitant is more significant than the one of netopitant. Rolapitant, on the other hand, although it is metabolized through CYP3A4, it's not an inhibitor or inducer, so there is no need to reduce the dose of dexamethasone. Rolapitant is an inhibitor of CYP2D6, and CYP2D6 participates in the metabolism of all cetrons except granisetron, which may limit the choice of cetron partner for rolapitant. In the new version of NCCN guidelines, it is stated that rolapitant has fewer DDIs compared with the other two. And let me close with the last criterion, and this is the convenience of dosing schedule. Here you can see MASC ESMO guidelines for highly emetogenic cisplatin-based chemotherapy. In the acute phase, a 3-drug regimen is recommended with NK1 inhibitor in blue, cetron in orange, and dexamethasone in green. If you use a aprepitant on day 1, it should be continued also on days 2 and 3. Metoclopramide has shown a similar efficacy in the delayed phase, so you may use metoclopramide instead. If you use other NK1 inhibitors, they are given on day 1 only. And of course, dexamethasone should be continued in the delayed phase. This slide shows the number of antiemetic administrations. Every administration of an antiemetic is calculated as 1, regardless of the number of pills. And you can see it for different antiemetic regimens containing different NK1 inhibitors. On day 1, this number is always 3, except for NEPA, because in NEPA, NK1 inhibitor and cetron are already combined. Unlike the others, aprepitant has to be continued on day 2 and day 3. So together with dexamethasone, NEPA has the lowest number of antiemetic administrations. This is the recommendation for AC breast cancer. Again, a 3-drug regimen should be used for the prevention of acute CINV. If aprepitant is used on day 1, it should be continued also on days 2 and 3. Dexamethasone has shown similar efficacy in the delayed phase, so you may use dexamethasone instead. For other NK1 inhibitors, there is no need to use anything for the prophylaxis of delayed emesis, and again, NEPA has the lowest number of antiemetic administrations. Oh, sorry. Now for carboplatin, these are the recommendations for carboplatin, the new expanded indication for NK1 inhibitors. Again, 3-drug regimen in the acute phase. Aprepitant should be continued in the delayed phase. With other NK1 inhibitors, no need for anything else for the delayed prophylaxis. And again, NEPA has the lowest number of antiemetic administration, and it seems that NEPA has the most convenient dosing schedule for physicians to implement and patients to follow. Unfortunately, not all of us have NK1 inhibitors available, especially for AC chemotherapy and carboplatin. So my last question is, if NK1 inhibitors are not available in your country, which antiemetic would you choose as an alternative? Thalidomide, olanzapine, or ginger? So please vote. So let's conclude. Guidelines consider all NK1 inhibitors equally effective for CINV prevention. No differences in efficacy and tolerability were identified between NEPA and the aprepitant granisetron regimens in the first comparative study published this year. The choice of NK1 inhibitor may be influenced by convenience of antiemetic schedule, availability of different routes of administration, drug-drug interactions, and cost. Thank you for your attention.